After
Audio
this,
recording for this meeting has begun.
there you go. After this, we will post this on our website. My name is Neil Rana. For those of you who have not met me, I'm the NCSC Health Equity Manager. I moved into this position in January, so I am pretty new to the position, but learning a lot every day. And I thought I would start by giving a little bit of a background, just a brief background on both of our speakers today. So Dr. Susan Blake and Dr. Dimitri Daskalakis will be giving the presentation today. Are you both on the line?
We are present and accounted for.
Great. So great to hear your voice. I was just going to give a quick bio, if you guys don't mind. As Disease Control Deputy Commissioner for the New York City Department of Health, Dr. Daskalakis has contributed significantly towards ending the epidemic efforts in New York City. His work at New York City Department of Health and Mental Hygiene has helped increase access to PEP and PrEP, address stigma and disparities among those living with HIV in New York City, resulted in historic decreases in HIV infections. He has emerged as a true leader in HIV treatment and prevention at the national level. And joining us as well is Dr. Susan Blank. After completing her residency at Yale New Haven Hospital, Dr. Blank joined CDC's Epidemic Intelligence Service in Environmental Health. She has continued to work for CDC in the Division of STI Prevention and is a CDC field assignee to the New York City Department of Health and Mental Hygiene. There she directs the Bureau of STD Control and is an assistant commissioner. So without further ado, I'm going to hand this off to Dr. Blank and Dr. Daskalakis.
Thank you very much for having us. We're really excited to be on this call. And so Sue and I are going to be splitting up this talk, and I think I am first up. Let's see if I can advance the slide. So our objectives briefly will be to talk a bit about the epidemiologic urgency of mobilizing novel HIV prevention strategies like PrEP. We're going to focus on New York City, but I think we'll convince you that there's an urgency throughout the country, if not the world. Better understand how to implement and support PrEP in diverse service models. So we'll focus a lot on our sexual health clinics, but you'll hear a little bit about how we're implementing PrEP with our contracted providers. And then ultimately we're going to end talking about the million-dollar question, how PrEP, STI, and sexual health interact to achieve a new normal, given the vast changes that are happening in both HIV treatment prevention as well as STI management. So with that, I'll start with the story of our epidemic in New York City. A couple of things. This is a graph that really shows the history of the epidemic looked at through the eyes of surveillance. You'll see a couple of very notable observations that something happened in the mid-90s. Very often when I ask this question and I point toward the new AIDS diagnoses decreasing and HIV-related deaths decreasing, people always point toward antiretroviral therapy only as the reason for this. And in New York City, it's way more nuanced. It is both antiretroviral therapy and syringe exchange for drug users. So antiretrovirals plus harm reduction resulted in what was really the first indication that this epidemic could be controlled. The second line that I want you to focus on is the black line, new HIV diagnoses that are going down, but not going down as quickly as these precipitous drops that we saw in the mid-90s. If you were to dissect this line, you would see that our rate of new diagnoses among injection drug users, or people who inject drugs, is crashing down. So it used to be that we would have about 1,000 new diagnoses in 2001. As of last count in 2015, we had 60 in 1 year. Similarly, maternal to child transmission has also crashed down. We had 0 live births with HIV in 2015 and 1 in 2016. The reason I bring this up is that what really is continuing to drive this line is ongoing transmission among men who have sex with men. What we see is that despite messaging around condom use, we're not really making the strides in that population that we did in people who inject drugs and in women who are conceiving babies. So when we look at this, I really think that the New York strategy is to look at the history and say what worked in the 90s. And what worked in the 90s was an antiretroviral intervention blended with harm reduction. So we're going to try to postulate for you that pre-exposure prophylaxis is the equivalent of syringe exchange for sexually active individuals unable to use condoms 100% of the time, especially if they are in a epidemiologic environment where they're at high risk for HIV exposure. The other comment I wanted to make is that decrease in new HIV diagnoses in a universe of declining or stable condom use is likely primarily driven by viral suppression. So New York City signed on to undetectable is equal to untransmittable, which is the notion that people with viral suppression do not transmit HIV. And I think as we're seeing higher and higher rates of viral suppression, that line is going down. When you overlap PrEP, the line goes down faster. And not to give a spoiler alert, but in the last year, with PrEP implementation resulting in 30% of surveyed MSM saying that they are on pre-exposure prophylaxis, we saw about a 15% drop in 1 year among new diagnoses among MSM and an 8% drop overall. We also saw a slight increase in women, which is why we are reinvigorating our program with our new campaign, Live Sure, to try to get the word out for PrEP for women. So with that, the story is, our strategy is harm reduction along with antiretroviral interventions. So this is a deeper story of our epidemic. You'll see that the majority of our new diagnoses are male. When you look at that female bar in the first cluster of bars, 91% of those women are Black or Latina. So it would be a really terrible thing if the mathematical prediction comes true and we're able to end the epidemic in only some pockets of our population, therefore the desire to reinvigorate work, especially in women of color. Black and Latinos make up the majority of new diagnoses. Age is the disparity. 20 to 29-year-olds are the belly of our new HIV diagnoses, but the problem really comes before they're 20 when they're not accessing prevention services. And the good news in New York City and New York State is that HIV has been recategorized as a Class B STD, which means that now our youth can consent for PrEP without express parental permission, which is great news. Again, MSM are the majority of new diagnoses, and poverty is a strong marker of potential HIV exposure and diagnosis. So that is really the story of our challenge, as well as our as the work that we've done so far. In terms of the HIV care continuum, as I said, a lot of the strides that we're seeing in reduction in new diagnoses really can't be attributed to PrEP yet. Most recently, we can point toward PrEP and say this has been a big piece of the story, but it really had to do with viral suppression. So we are probably one of the best tested jurisdictions in the world. 95% of our people living with HIV are aware of their status. Of people living with HIV, 82% are on antiretroviral therapy, and 76% of overall people living with HIV are virally suppressed. For those of you that follow the UNAIDS Fast Track City 90-90-90 plan, we are 95% diagnosed, 86% prescribed antiretroviral, and 92% of those on antiretrovirals are virally suppressed. So we're getting there. And again, viral suppression is a very powerful way to prevent HIV transmission, which is a key part of our prevention strategy, almost inextricably intertwined with PrEP. It is pretty much one story rather than two. And so to end the epidemic, one of the most important things that we're doing is really looking at strategies, and we have a recipe that revolves around science, community, and political will. So first, the science. I think I've made a pretty good argument for you that undetectable is untransmittable, and that we are a very large demonstration project of that theory, and it looks like that theory is true. Condoms are our very favorite first line of defense. We distribute 37.5 million of them, male condoms every year, and some female condoms as well, and then all sorts of other varieties. So we're not giving up. We keep covering, Dr. Blank keeps covering the city in high quality New York City latex, and we will not stop. But for those individuals unable to use condoms 100% of the time, and who are HIV negative, we have really launched pre and post-exposure prophylaxis in a pretty significant effort. And so the next step after science is activism. So I think those of us who do clinical medicine or in public health know that very often science moves quickly and then implementation is hard, and it takes a lot longer. So when your community back from the 90s said implement change quickly, as that picture of Peter Staley being dragged away of the FDA would demonstrate, And then that same community, flash forward 2 decades, 3 decades later, are arrested in front of the White House and say, we're going to end the epidemic of HIV in New York State, and that means that we're going to make public health and the politicians do it now. That really is the second ingredient in ending the epidemic. And then finally, when people step up, like our governor and our mayor, and say we're going to put energy and also resources behind this, we're able to go from a glimmer in our eyes of a plan to what is actually an implementable blueprint. Now, when the governor said end the epidemic, we think he's a wonderful politician, but he is not a clinician or a scientist. So what he did is he enrolled some smart people, including David Holtgrave, to come up with a model of what it means to end the epidemic of HIV. So the idea is that we will do something to reduce new HIV infections to an inflection point where fewer people are entering the system than exiting the system. And what that does over time, although I think this graph overestimates how quickly, is that the prevalence of HIV in the jurisdiction will also go down. So as fewer people are entering and people are exiting through natural causes and not because of AIDS deaths, we then see the curve bend. And the inflection point, the number that was modeled for the state, was 750 or fewer new infections by 2020 to achieve this goal. Now, how to do that? We've been doing a lot of it already. The first is test more people. The second is link them to care because it's good for them and also good for transmission. And then finally, facilitate access to pre-exposure prophylaxis for HIV-negative persons at risk. So that really is the focus of the majority of this presentation. Now, after the governor came up with these 3 pillars, the community gave a lot of feedback. A task force was convened in October 2014. Through the fall and early winter of 2014, we commuted back and forth from Albany. For those of you who know what that means, it was cold and miserable, but we did good work and actually generated some really good recommendations. And all New Yorkers in the room did something rare. They unanimously agreed on all the recommendations. And in January 2015, the blueprint was released. And then all of the fun began. So the blueprint comes out. April 2015, Governor Cuomo accepts the blueprint in its entirety. Then the New York City and New York State Departments of Health had some very serious conversations with the community. I've shown some pictures of some of the folks who were involved. And then ultimately what happened is Mayor de Blasio, the mayor of New York City, actually made a $23 million investment in ending the epidemic, making us the first jurisdiction that put money behind the concept of ending HIV. And so then what we did was we declared HIV an emergency one more time. So I showed a map from the CDC that demonstrates the estimated lifetime risk of HIV. You'll see that New York has a 1 in 6 New Yorkers have a 1 in 69 chance of becoming HIV infected at some point in their lives. So we approximate the Southern epidemic pretty well. And so what we did was activated in New York City Department of Health our emergency response system in effect. So we had meetings with folks from finance, administration, facilities, everybody, until we actually had a plan moving. And for those of you who've ever worked in government or academia, this is a pretty impactful statement. We hired over 100 people and implemented over 60 contracts in 1 year, which is a very rare event. It's a huge and rare event. So, with all that said, New York City likes to be precocious, and if the governor has 3 pillars, we add more. And so we decided to create an implementable plan for HIV epidemic ending, and this is what we came up with. Transform STD clinics into destination clinics for sexual health services, make sexual health clinics efficient hubs for HIV treatment and prevention, launch PrEP and repair nPEP delivery, support priority populations using novel strategies, make New York City viral suppression go from good to excellent, and finally, make New York City status neutral. And that means not focusing on people's status, but just the services that they need to make themselves healthy. So one test and one pill should not create a universe of stigma. And so that's been a guiding principle in the work that we're doing. We're going to focus primarily on all of the PrEP interventions in the sexual health clinic as well as with our contractors. So there are a few buckets I'll go over. Promoting PrEP to potential users, so we'll talk a little bit about our media and social marketing campaign. Promoting PrEP to potential providers. I'll talk to you about our public health detailing program as well as some of our other work. And then I'll hand it over to Sue, who's going to talk a lot about what's happening in the sexual health clinics. And then we'll talk a little bit about awareness and uptake and the role of STI. So how do we promote PrEP to potential users? That was an important part of the strategy. And in 2014, on the same day that the governor announced that we were going to end AIDS and put PrEP on the list, New York City put out its first ever PrEP and PEP awareness campaign. And this graphic, the Share the Night Not HIV with the little PrEP bubble, that at one point was our most popular social media post in New York City in the history of using social media for the Department of Health. It was. It was only recently surpassed by when a celebrity retweeted one of our PlaySure campaign ads, and then we sort of caught fire. But that's earned. But just by doing this alone, we actually got a lot of sort of folks talking about PrEP, even as we were figuring out how to actually implement it in our jurisdiction. So we then followed that up by realizing that it really wasn't status neutral. It was only about HIV negative people. It didn't really blend the reality of the scenario, which is that the best way to prevent HIV is combination prevention, and you have to pick the combination that works best for you. So that is the principal message of PlaySure. And if you're listening to the name PlaySure, it is a double entendre on purpose. It sounds like pleasure, and yes, most New Yorkers understood it. So we wanted to focus on fun, we wanted to focus on pleasure, and that you can have pleasure and also have a plan to prevent HIV and STIs, and that it tends to be a combination strategy. It was launched in 2015 as PlaySure. It launched again in 2016 as StaySure, and though we don't have images of it, I don't think, in this presentation, it just launched in the last 2 weeks as LiveSure, which is a campaign focused primarily on women. And in the future, in the cards very soon, is a campaign for Spanish-speaking New Yorkers that will be made in Spanish and translated in English. So it's going to be a little bit of a change for our strategy. We also created a piece of swag that is status neutral, that encourages people to play sure. It's a kit. You'll see a picture of what looks like a little metal kit with lube, 2 pills, those are Stribil, the HIV medicine, and condoms. So the story of this is one of my patients came to clinic and showed me that this was his prevention tool, which was a little packet where he had our high-quality New York City condoms with lubricant and his HIV meds, and he said, I have this in my bag and I have it wherever I go in case I'm in a scenario where I don't have things close by. And so we sent that to an industrial designer. We produced what's called the PlaySure kit. We got fancy artists and designers, most recently Marc Jacobs, to work on it, and we've given out about 200,000 of them. Sort of making the point that if you take pills and condoms and lube and put it all together, somewhere in there is the right strategy for you. Whatever works, whatever you do, it's in the right direction.
Now, as you go.
So then,
sorry, Dr. Oskowski, give me 1 second. I just wanted to encourage everyone to mute their phones if they joined a little later during the presentation. Just mute your phones, please. Go ahead. Sorry about that.
Yeah, no problem. So then talking about providers, so we did a pretty good job of canvassing the city, letting people know about pre-exposure prophylaxis and how it fits into a story with PEP and treatment. But we also had to get the word out to providers, which frankly was harder. So we did that with a detailing campaign. So I'll start by saying New York City Department of Health has a pretty long history of being frequent users of detailing. And so what that means is that we actually took a page out of the pharma playbook, and we hired people who were former drug reps, and we trained them to be able to go into practices to teach people about PrEP and PEP. So they weren't selling a drug, they were selling a strategy, and that strategy was very, very heavily influenced by a vision of sexual health and sexual well-being, followed then by messages about PrEP. So 5 of these folks were hired. We actually did not just send them out randomly. We picked facilities based on our surveillance. So that included institutions that had newly diagnosed at least 1 person with HIV. We selected either primary care or infectious disease clinics or practices. Preference was also given to facilities that diagnosed at least 1 MSM of color with HIV, or were located in a designated high-need neighborhood. Additionally, we used syphilis diagnosis and eventually rectal STI diagnosis as well as a guide to identify places where we should go promote pre- and post-exposure prophylaxis. This is a picture of version 1.0 of our kit, and the two most famous nurses in Staten Island, who we've been using this picture a lot, who I actually did a random site visit to their clinic, and they had already been detailed, and were like, why are you here again? And so they were actually looking at our detailing kit when I landed there, as they were trying to figure out how they were able to implement or start to implement some PrEP messaging in their clinic that was doing a lot of sexual health work. And so what we found in our post-visit from the detailing campaign was that providers that we detailed demonstrated increasing knowledge of PrEP efficacy. All of the asterisk bars represent statistically significant changes. We saw that they were taking sexual histories from their patients, not all the time, but at least they were doing it some of the time. We did not see an initial increase in PrEP, but I'll tell you that in future data we did see, imagine because they actually had more opportunity over time to see people who were potentially exposed. So we did see an increase, but not in the first round of evaluation. We also saw an increase in PrEP discussion, and then ultimately we saw an increase in PrEP prescription, which was, again, statistically significant. A couple of things that we noted that overall, there was an increase among all providers. The biggest increase was among infectious disease providers, which is fraught with a little complication called the purview paradox. So since they are the ones that know how to prescribe tenofovir and emtricitabine fixed dose combination, which is approved for PrEP, they're however the ones least likely to see folks who are at risk just randomly, because they're sort of self-selecting folks who are living with HIV. So on the flip side, primary care doctors may not be as comfortable using PrEP prescriptions, but they see folks at risk more likely than the ID provider. We did see increases in both. What we did not see an increase in is prescriptions among nurse practitioners and physician's assistants, and that's because of us, not them. So we actually did not detail their collaborating physicians. And so our strategy changed, and we include collaborating physicians in the detailing when we encounter NPs and PAs. We also have a PrEP implementation workshop, which has been developed in cooperation with Sarik Golub from Hunter College. It is a 1.5-day work session where we bring together the movers and the shakers from the clinic to figure out how they're going to implement PrEP. And that means administrative directors as well as medical directors. We drive them through an entire therapy session, really, about how they can implement PrEP in their environment and how they can customize it. We show them really good PrEP protocols, and then ultimately they leave with a pretty solid skeleton of what a PrEP protocol looks like. It is now a part of our capacity building work with the CDC. So it's something that you can get in your jurisdiction if you're interested. So I'm going to pass the baton over to Dr. Blank, who's going to talk about implementing PrEP in different environments.
And the environment, hi everyone, this is Sue Blank, and the environment I'm going to talk about are the STD clinics, as they were once known, and tell you why they were really critical for this effort in terms of increasing diagnoses, maximizing diagnoses of HIV in New York State, increasing treatment and viral suppression, and increasing prevention. The then STD clinics really accounted for about 10% of the new HIV diagnoses in New York City, and that's still the case. And in particular, 20% of the acute HIV cases diagnosed in the city are diagnosed in the STD clinics. So that's actually pretty considerable when you imagine that these are the folks who are most infectious. The STD clinics are also a safety net for some persons living with HIV and AIDS who are not connected to care. And the existing models of immediate ARV starts for newly diagnosed patients is thus really ideal for this setting. The data support that treatment is prevention, and the STD clinics do have this proven track record for connection to care. Here we go. As far as the HIV positives are concerned. For the HIV negatives, one of the things that is worth noting is that we have had an opt-out consent for HIV testing since 2008. We've done some surveys of our patients, and 65% of our patients surveyed at the STD clinics would start PrEP at the STD clinics if it were available. This is from a few years ago. And our data demonstrate that patients diagnosed with syphilis and with rectal STIs are at very high risk for HIV, and I'll get into that a little bit more in a moment. And potentially thousands of PrEP candidates were being seen annually in our clinics. So we also have demographically a diversity of clients, and our service delivery environment really supports the STD clinics as a gateway to primary care and biomedical prevention for HIV negatives. So you can see we talked about the positives, we've talked about the negatives, and this is really, we have something for no matter who you are. Even if you're HIV unknown, we have testing. And that gets back to what Dr. Daskalakis was saying about status neutral care. There is something that is going to help prevent HIV in the population for anyone who comes in the door. So this is, for those of you who are the epidemiologists in the crowd, really the money shot. We are really, we've done a variety of studies looking at our patients in the city in general. And one of the things that we found from our clinics was that 1 in 42 HIV negative MSM attending the New York City STD clinics were diagnosed with HIV within 1 year. If we looked at HIV negative men who were diagnosed with primary or secondary syphilis in New York City, 1 in 20 would be diagnosed with HIV within a year. And if we look at HIV negative men who are diagnosed with anorectal chlamydia or gonorrhea, about 1 in 15 such MSM who were seen in the STD clinics were diagnosed with HIV within a year. And one piece of perspective is that the STD clinics diagnose about 25% of the city's PNS syphilis, and probably a larger chunk of the anorectal infections, but overall about 15% of the gonorrhea infections. And let's see. So this is one of the favorite things we like to show people. Another reason why the STD clinics are really important, given what you just learned about HIV in New York City. If we look at reported primary and secondary syphilis cases among all males, and we looked and we mapped them out by the reporting facility using little dots for those neighborhoods, and does this thing work as a pointer here? And that the size of the dots represent the number of infections diagnosed per healthcare facility. You see that there are pink dots and blue dots. The blue dots represent the sexual health clinics, which were once known as the STD clinics, and the red dots represent all other providers. And what you can see is that there is a preponderance of red dots in Manhattan, and then a scattering of dots up here in the Bronx, and then throughout the boroughs. And you still see that these blue dots, though, we're still there. But if we then ask the same question, we ask for the same mapping, and we look strictly at reported primary and secondary syphilis by reporting healthcare provider, but only among the white non-Hispanic males. Again, same sizing of dots representing numbers of cases, and blue representing the clinics, and pink representing all other facilities. The thing that really hits you about this map compared to the prior map is that the blue dots all but fall off the map. But if then we were to do the same map, once again, reported PNS syphilis among men of color by reporting healthcare facility, what you see is that the pink recedes a bit, and now we see the blue dots coming out. Earlier, you had heard that HIV cases are occurring among men, particularly Black and Latino men, and what we're seeing is that you just saw that syphilis is an important antecedent, or at least potential antecedent, to an HIV case, and you see that a lot of them are being diagnosed in the STD clinic. One of the other important things, so as we were looking at all these data and seeing how important the STD clinics were in terms of having a role and getting people connected to whatever HIV service, or assuring that they are connected to whatever HIV service they needed, our flagship clinic, the Chelsea STD Clinic, which was being under a much-needed gut renovation, had to move its staff to a site uptown in Manhattan, and that unfortunately was done without really consulting our community partners, the activists who were so critical in getting this framework implemented. And that really lit a fire because we took a lot of criticism for having done that without the community being involved. And as a result, that really did push the investment in STD services insofar as it really brought them to sort of the front burner as the community was outraged by the lack of services. We did a variety of things to make our services more destination clinics than these sporadic visits. Treat and street was no longer going to be the way we operate. We really wanted these to be destination sites, and we wanted to make sure that we could, have the wherewithal to provide the services that were needed, even if that was more than one visit. We expanded our hours to improve access. We included evening hours and Saturday hours in select clinics. We made our part-time clinic, our one of 8 clinics that was part-time, we've expanded to 5 days a week. And all of the clinics, we hired triage nurses to do the front door greeting, essentially. We also restored our clinic ability to provide screening services or express visits for asymptomatic clients. That was something that fell to budget cuts in prior years, and now this was being restored. And as an audience such as you folks would know, for bacterial sexually transmitted infections, most of them are asymptomatic. So it's really critical to have those services available. It also makes it a much more welcoming place because it's not the stigma of knowing you have an infection to walk in. It's just because you want to take care of yourself, and you just feel you need screening. We modernized our diagnostics. We enhanced our HPV-related services with HPV vaccine. We're also in the process of introducing quick start contraception for women, which includes not just emergency contraception, but an option of moving onto pills or depot, and we will soon be enhancing that menu of potential contraceptives. And we did a new clinic video for patients in the waiting room. Welcome to the clinic. Also, what we found was that we, in addition to having, for the first time, having funding that we could allocate to advertising, because although we have 8 clinics across the city, it was primarily by word of mouth. We really wanted to get the attention of New Yorkers to let people know that we were open for respectful services that did not really care about HIV status, but really was there for the community for whatever their sexual health needs would be. And here you can see on the right some of our subway ads, which were actually very well received. They were rather cheeky. And as the clinic closure that I told you about that happened in 2015, last week we finally reopened the clinic. It is really gorgeous, and we're thrilled to be able to share that grand opening with our community partners. As far as what our the new Chelsea Sexual Health Clinic, notice it is not an STD clinic, it is a sexual health clinic. The architect was Steve Diablon. He does do health centers of a variety of uses. This is a LEED building. He has experiences doing designs for the health department. It takes in a lot of natural light and views of the park just outside the clinic, which is really, it is just such a soothing place. And you can see the wood, and just the brightness of the space. Very welcoming for someone who wants to come in and take care of their sexual health. So what are some of the state-of-the-art HIV interventions in our clinic? We now provide full courses of nPEP, or just we call it PEP 28. Before we were doing starter packs with referral to another site. We do the entire PEP course, as well as the clinical and laboratory monitoring that's involved. We do immediate PrEP starts for patients, and we do what we call jumpstart, or for patients who test positive for HIV, either via rapid test or via the acute testing that we do, we will get them started on HIV meds that day and send them home with the first month of meds, along with a more prolonged interaction to make sure that all of the administrative hoops have been jumped to assure a smooth landing into primary care. Again, the biomedical evaluation and intervention amounts to instant starts of ARV treatment and prevention. We also, as far as the 100 hires that Dimitri talked about earlier, this included not only our triage nurses, but social workers who could assess for social determinants of risk or disease prevention, and patient navigators for insurance connection. Those connections would be for longitudinal care. And that didn't matter if it was someone who was HIV negative and wanting to pursue long-term PrEP, or for somebody who's HIV positive and fallen out of care. So it's not just a plan. We really did make ourselves hubs. This is a slide that as of 3/10/2018, we've navigated since this is as of 3/10/2018. Since we first began on Halloween of 2016, we've had over 6,700 PrEP navigations. We've provided PEP 28 to 1,571 patients, 60% of whom are Black or Latino. We launched Jumpstart just before Thanksgiving of 2016. Again, we did this as a rollout starting in one clinic. We now have all 8 on board. And we've jump-started 272 HIV cases. 72% are Black and Latino. Again, getting them jump-started, we believe is enhancing and accelerating the course to viral load suppression, making disease transmission untransmittable in the U=U formula. And we've initiated, since December 22nd of 2016, we've rolled out clinic by clinic. We're now at 5 of our 8 clinics, and we've provided PrEP starts, 1 month of PrEP, to 1,213 individuals, 57% of whom are Black or Latino.
Great. So beyond the STD clinics, or the sexual health clinics, I still slip up. So beyond the sexual health clinics, we also, part of our strategy was supporting community-based organizations and clinical providers to improve work in PrEP. So what we did was we funded organizations using Ending the Epidemic money to kiss what they do with PrEP. So rather than creating something new, reinventing the wheel, we made places that did good work already add PrEP to their repertoire. So what that means is, if you went to a New York City supported testing site funded by the PlaySure Network, you would be screened for PrEP eligibility and you would be offered a referral for PrEP. If you were to say that you had a social issue, so let me pretend that I got tested, I'm negative, and I say I have a problem with my housing. Somewhere in that PrEP PlaySure Network is someone who can help me with housing. And so the PrEP navigator acts as the bridge to take that person to the community-based organization. That person gets whatever needs to get done from the social perspective done, and when they're ready, which can happen at the same time as while they're working on their social issues, they're referred to a clinic where they're able to start PrEP. Now, they could land in any part of this network. So they could start at the clinic and then end up going for future testing at a testing site or for services at a community-based organization. One of the interesting things about this network is that the arrows that you see are not just theoretical, they represent memoranda of understanding with cross-linkage, and there's incentive for people to be referred between sites if necessary. So what we've done is create a web of prevention over New York City that complements the work in the sexual health clinics. And we've done other PrEP and PEP initiatives. We've funded 3 adolescent-focused PrEP and PEP sites that will integrate into the triads that have been funded. We actually initially started these sites hoping that we would get best practices And ultimately what's happened is, since there is now a change in policy and regulations, these sites are actually now more successfully putting people on PrEP. I'll say that along with the almost 1,300 patients started on PrEP through the sexual health clinics, another approximately 800 to 900 were started through the PlaySure network. So these so far have been fairly successful. Given the fact that current estimates by Gilead is that 17,000 people are on PrEP in New York State, increasing that number by 2,000 in 1 year is fairly remarkable. New York City was also funded to adopt Ryan White care coordination programs for HIV negative people so they could engage in preventive services. So we did not use Ryan White money, but we used a Ryan White infrastructure and it gave money through ending the epidemic so that those programs could see folks who are PrEP and PEP candidates, folks recently diagnosed with an STI, and we also added hepatitis C support as well to try to give more options given the maturity and really efficacy of that Ryan White care coordination program. We created a provider directory. New York State has one too. Theirs is fabulous. It is, however, unvetted. You don't have to go through a screening process. Ours has to go through a screening process. So we have fewer providers, but we have more assurance as to the quality of the provider. We have citywide training for frontline staff and continue to do work to promote comprehensive sexual and other health care for MSM, which will heavily include pre- and post-exposure prophylaxis. Now, before I hand it back to Sue, where she's going to talk about PrEP and STIs, if a tree falls in the forest and no one's there, does it make a sound? It's pretty much the story of PrEP as well. If no one is watching what's happening, then how well do we know that we're doing? And so I'll show you some of our strategies for evaluating PrEP uptake and remind you that one of our shortcomings, not only in New York City, but I think in the U.S. in general is, since we don't have a single payer provider system, there's a lot of ways to get drugs. We don't have really, I think, a very convincing way to do pharmacosurveillance, unlike places like Canada and Great Britain, where a single payer means they know exactly who's getting what drug, who it's going to, how many times they refill, etc. So I think because of our system, we have to sort of feel around in the dark a bit. And one way that we've done that is with surveys. So we created something called the Sexual Health Survey. It was administered to MSN 18 to 40, both live and online, as well as to women who are potentially at risk for HIV. I'm only showing you the data for MSM because I don't like showing a graph with no bars on it, since the story in women is that we haven't really seen a lot of increase in women taking PrEP. But we have seen in men who have sex with men that more and more folks who are PrEP candidates are going to providers, talking about sex, talking about PrEP, and ultimately about 30% are going on pre-exposure prophylaxis. Interestingly, in these data, we do not see a disparity between Black, Latino, and white men who have sex with men. On the other hand, other data that we use is something called PCIP, which is a Primary Care Information Project, which is a surveillance system that takes a sample of clinics who've agreed to participate and looks at their EMR data through a back office mechanism. And we're able to see PrEP prescribing using the same algorithm that has been proposed in NHAS as well as by Gilead. And so what you'll see is that we've seen increases in PrEP uptake overall, that's the green line, since Q1 of 2014. The majority of that increase has been in men, with really what looks like a flat line in women. When you look at the racial issues around who is getting PrEP prescribing, what we would see in this data, though we're not showing that slide, is that that white men are the majority of PrEP prescribing. So two different data sources are showing us some disparate data. So in one set, we're showing no disparity, and in the other set, we're showing the same disparity that the rest of the country is experiencing. And with that, I'll hand it back off to Dr. Blank.
All righty, I'm going to talk a little bit about PrEP and STIs. This is a very busy slide, but it does show information from San Francisco, where basically they showed that screening more frequently brings out or diagnoses more infections. The graph on the right shows you the percent of infections that are diagnosed, of each of the infections you can see along the x-axis, that are diagnosed by if you were to screen every 3 months or every 6 months. And the dark brown parts that you see on the tops of those bars represents that delta that you yield by screening every 3 months instead of every 6. So the take-home message from that part of the slide is Q3-month screening is much more likely to give you a higher yield than Q6-month screening. And there's a lot of intervention that can be done with the results that you yield on 3-month screening. On the right, what you can see is that no matter where you look, most of the infections are asymptomatic. The only difference, the only exception to that is with urethral gonorrhea, of which there are only 31. But when you look at all of both gonorrhea and chlamydia as a pathogen, for all of the extragenital sites, you can see that asymptomatic infection is the predominant form of infection that's diagnosed, which tells you what? Screen, screen, screen. And if you look at the lower right, what you see is the number and percent of infections in this particular study that would be missed had there not been extragenital screening for chlamydia and gonorrhea. And you can see that regardless of which infection it is, it's actually quite substantial. 83% for gonorrhea and 76% for chlamydia. So the question comes up about HIV prevention efficacy, and what you have here is a list of the key studies that really show you that you really do have, that there is really effective regimens for preventing HIV. And you can see that from the IPREC study, the Kaiser Permanente study, the PROUD study, the E4Gay study, and the PARTNER study. Basically, each of these replicated the great efficacy of PrEP as a mode of preventing HIV. The thing is, each of these studies had extremely high rates of STI and lower than expected rates of HIV. And what does that really mean for us? Well, what is really important is, A, that PrEP as a strategy is great for preventing HIV. The fact is also that STIs existed, will continue to exist, and to remember that STD and HIV transmission risk may be uncoupled with ART on board, but it's a new reality, and we have to evolve how we harmonize HIV and STD prevention. And it's actually not that dissimilar from discussions that had happened around contraception years back, as sex for pleasure and procreation could be uncoupled. This is really something equivalent.
Having a healthy baby. Start being healthy yourself. Did you know that taking a multivitamin with folic
please
acid,
mute your speaker,
spacing pregnancies at least 2 years apart, and keeping your prenatal visits can increase the chances of a healthy baby? Learn about our free home visiting services for women who are pregnant and for infants. For more information, please call 253-1390. We want your child to have the biggest and brightest smile he or she can have. Our dentists provide examinations, cleaning, and other dental services for children from 3 to 20 years old. If your child needs a dentist, please schedule an appointment today. For a healthier lifestyle, adopt 5210. The healthiest way to go. Consume 5 or more fruits and vegetables every day. Keep recreational screen time to 2 hours or less every day. Engage in at least 1 hour of physical activity every day. Drink more water and 0 drinks. Take the pledge for a healthier lifestyle. Go to www.5210jax.org. Breast milk, or human milk, provides the first complete nutritious food for babies. For answers on how to get started, call the breastfeeding line at 253-2083. Support and help in reaching your breastfeeding goals.
Are you guys able to put everyone else on mute, like through a...
Keep your life
we're trying to...
Call 253-1130 for an appointment with one of our licensed... You have been muted.
Can you,
Your microphone has been turned
Dr.
on.
Doskalakis, can you still speak or? Yeah. Dr. Blank, can you hear or?
Great. Can you hear us now?
Yes, we can hear you.
We're back.
Okay. So,
Sorry about that.
That's okay.
So in addressing the disconnect between when we talk about HIV being preventable by pill and STIs being preventable still via condoms for the most part, it brings us to this. Seatbelts don't prevent cancer. Seatbelts do prevent death and injury in car accidents, but they do not prevent cancer. PrEP prevents HIV transmission. It does not directly prevent STIs. So use a seatbelt to prevent injury and to make it safe to go to the colonoscopy suite. PrEP prevents HIV and gets you to sexual health. Aha. So PrEP is not antithetical to sexual health-focused prevention strategies. In fact, PrEP is really a gateway to sexual health-focused care for the very populations that healthcare has not adequately served. It's an opportunity to increase sexual health service and delivery as well as the quality of that service. It's recommended as a part of a comprehensive HIV prevention package that includes STI screening, and reminder, speaking to the choir a bit, but it needs to be correctly done in all the right anatomic sites and regardless of the presence of symptoms, as the word screening would suggest. And it includes risk evaluation and reevaluation. And with the increase in PrEP uptake, there is an opportunity to improve STI screening frequency with the right testing strategies among MSM at risk for HIV exposure. And there's also an opportunity to address contraception in the appropriate populations, and it's an opportunity to leverage HIV resources to strengthen the sexual health infrastructure. So STIs among MSM following PrEP. Well, PrEP could reduce STI incidence over time. At 40% PrEP coverage and 40% risk compensation, that is reduction in condom use, 42% of GC infections and 40% of chlamydia infections could be averted over the next 10 years. And a doubling of risk compensation would still result in net STI prevention relative to having no PrEP on board. Because again, PrEP is a package. It's not a pill. It is a strategy that includes that pill every day, plus the use of condoms and contraception as appropriate to the individual. There is no support for the causal hypothesis of higher incidence of bacterial STIs among PrEP users because of risk compensation. And when we looked at our data in New York City, our STI rates, they have been going up among men, particularly men who have sex with men, for years now, even prior to PrEP really hitting the scene. And so what we're seeing is more of what we've seen. And PrEP does not appear to be causal in any of this. It's important to optimize PrEP-related STI screening. Again, we stand behind the 3-month recommendation, and that the study highlights PrEP as combination HIV-STI prevention when it incorporates STI screening and treatment. You want to?
I'm on again.
I'm turning it back.
Here I go. So finally, just to talk a little bit about our framework that we think is so important, how PrEP fits into our status neutral strategy for ending the epidemic. So I think in New York City we've done a pretty great job of making the point that something medical is a piece of HIV prevention. And by medical, I mean a pill linked to testing and other programmatic support. To the point that the New York Times even claimed that we revamped safe sex. We don't really take credit for that, but we'll take the compliment. And so I feel like the word is out, at least among MSM and now hopefully more among women, that PrEP is a very important piece that does involve some sort of linkage to preventive care. Now, I think we also made the point pretty clearly demonstrated by billboards in Times Square saying that HIV treatment is prevention, that people who are living with HIV, undetectable is equal to untransmittable, treating their HIV has a fabulous side effect of no transmission to their partners. So that, I think, has been very clear, a message out of New York City. So what we realized was that when you look at continuum of care, either for treatment or prevention, we keep coming up with this strange endgame, which is either viral suppression or beyond PrEP. So to people outside in the world, that sounds like what we're doing at the Department of Health in New York City is cramming pills down people's throats. And that is not at all the intention of our work. Instead, we've reinvented our continuum and look at it as a cycle. So the HIV test is the entry into the cycle. People who are diagnosed positive go onto the treatment engagement side of our cycle. Quality HIV primary care primes the pump and maintains these individuals in treatment. By being engaged in treatment that's high quality, guidelines are followed, people go on antiretroviral therapy immediately, and their viral loads become suppressed and they do not transmit HIV. On the flip side, if they're HIV negative, they enter the prevention engagement cycle. And what that means is that with high quality HIV STI services as well as harm reduction, they stay within that cycle, and if they need to be on PEP or PrEP, they go on it. So ultimately, the individual that we're treating for HIV whose viral load is suppressed can't transmit it, and the individual on PrEP can almost not get it. So we don't treat them as different people anymore. They're the same people. They get the same interventions. It all looks about the same. And those of you who do clinical care and see PrEP and HIV patients will probably attest to the fact that it's a little confusing now because the care looks pretty much the same. So given that, we thought that rather than creating a universe siloed between negative and positive, that we would make efforts by changing the framework to create one universe that looks at what people need rather than how many pills they take or the result of one of their tests. So that is really sort of the main sort of framework on which all of this PrEP work follows. Thank you very much.
Thank you so much, Drs. Blank and Dr. Daskalakis. That was really great. And I just want to say, on behalf of NCSC, thank you so much. And also, apologies for that audio hiccup. I have no idea what that was. But thanks for everyone for bearing with us. We are going to send out a evaluation, and we're going to share these results with the doctors as well. And if anyone, so if you could complete that, that would be great. And if anyone has any questions or comments, feel free to email me. My email is nrana@ncsddc.org. It's also listed on the event invite, and I'd be happy to connect you with some answers. So with that, I think that's...
One thing, so this is Sue Dimitri. We will hang out on the phone also if people do have some residual questions and time, is not an immediate issue. That's totally fine as well.
Great. Awesome. So then I'll keep the lines open for now. Does anyone have any questions they'd like to ask the doctors? Just go ahead and unmute your phone and feel free to, or type the question in the chat box. That's also an option.
Hello?
Hi.
Hi. We're implementing our PrEP program here at the DOH in Florida, and we are wondering how could we achieve a copy of the PrEP implementation workshop documents that you were speaking of?
So you could email me at ddaskalakis at health.nyc.gov or reach out to NCSD. They have my email as well. And if you reach out to me, I'll connect you with our PrEP implementation folks so you can see if we can get you some of the materials.
Okay, thank you very much.
Of course.
Looks like we have a question from Gail. She's asking, where did you obtain the ETE funds?
So ETE funding in New York City is pretty complex, but we got an investment from city tax levy dollars of $23 million that is ongoing. So it's annual $23 million to be able to support both the programming we presented here as well as several other programs that we don't have time to present if we're focusing on PrEP. So there is city support. And, oh, that's right. We also should mention that too. The state also provided support in a different way. So they provided some direct funding to some of the work happening in the sexual health clinics, but then also there's a match. So if the city puts up money, there's also some money that gets matched by New York State to be able to sort of maintain a certain clinical services. So not all any of the epidemic services have that match. Some do. I believe most of the services in the sexual health clinic, in fact, do have that match.
Right, and then in addition, we got some private funding through MAC-AIDS, also provided us with $500,000.
They jump-started Jumpstart.
They definitely did.
Thank you, and I also listed both of your emails in the chat if anyone would like to reach out.
Great, thank you.
Okay.
I should have put them on the last slide. Sorry, I forgot.
No problem. And again, if anyone has any questions, please feel free to write it in the chat or unmute your phone and just introduce yourself and ask your question. Okay, well, if no one else has any further questions, I think we can wrap it up. I think that, so if you do have any questions, those are Dimitri and Sue's emails listed in the chat, and I think they're open to receiving questions. And if you have any questions for anything related to the webinar, feel free to reach out. I will also type my email into the chat. And thank you so much for Dr. Blank and Dr. Daskalakis for staying for questions. That was very nice. And thank you again for your presentation. Did you guys have anything else to add? Okay, well, thank you, everyone. Have a great day.
Thank you.
Thanks.